First of all, let's take a look at the future of capitalism in the area of health and see how it's behaving today. It's the only area in which we've really got a lot of progress that's enabling us to live longer and better. So I'll call upon Julien Legrand. Please take a seat. Jean de Kervas-Doué and Philippe Leduc, our colleague, who's going to direct the debate. So I'm a doctor, and I'm also a journalist. And with Jean de Kervas-Doué and Julien Legrand, we're going to talk about how we can redesign health capitalism. But we expect a lot of you in this debate. Guy Valenciennes has set the bar very high because liberty, health, and equality, well, we do sort of understand what that means because there are a lot of things are unequal. You'll tell us what you think. You'll tell us whether you think that's important, whether they can be corrected. But the second theme that we're going to take a close look at is how to redesign health capitalism. Capitalism's a bit out of fashion today, and it's even more complicated when applied to health. But as Guy said, it's closely connected to the market economy. This is a sociological and political concept supported by private means of production, founded on private companies and a free market in an economic system where we use financial capital. Capital is something that's important, therefore. If he selected that word, it must be important. And to go back to language that is meaningful to all, we've got to think about something which is going to be not only efficient, but interdependent and supportive for all. Julien Legrand, you're a professor of social policy at the London School of Economics, and you've been at that position since 1993. You've been an advisor to Tony Blair, and you've thought about the inequalities in the health systems and in what you would call almost markets to improve the efficiency in education and health. Jean de Kervas-Doué, you were director of the hospitals at the Ministry of Health between 1980 and 1986. You were appointed by François Mitterrand, weren't you, more or less? Well, Pierre Mauroy, really. Well, it means the same thing, really, doesn't it? So for those 5 years of your career, you changed the way the hospitals were funded with what we call the PMSC, which is the global budget. And you set up the system by which procedures were paid for, which is now a system that nobody really agrees with anymore. And you're above all a writer. You're somebody who's very provocative, and although you're not completely on the left, you're not on the right either. So I think you could say you're sort of horizontal. And to find something that works in English and French in Great Britain or in the UK, we're talking about the England rather than Scotland. In England, there's a state system, and from 2003 onwards with Tony Blair, you tried to put competition into it and make the system a little bit more market economy oriented, whereas in France, we're talking about a liberal system, and we're going to go towards something that's a little bit Soviet-based, as Jean Kervas-Doué would tell us. So I think that we should take a look at inequalities. We'll start with Jean, and then we'll listen to Julien. 3 or 4 minutes. No, 5 minutes. Well, good morning, everybody. Guy has sort of set a trap for us here because trying to deal with all the aspects of health policy in 10 minutes is not only and not only medical policy, but all the political science that we've been through over the last 2 centuries, a bit of a challenge. So I've written a text which you'll get on the site if Guy would like to put it on. Concerning inequalities, I'm going to go through 3 subjects: inequalities as a whole, health inequalities, and then inequalities in healthcare. And I'd like to start with 2 quotes, one from Coluche and one from Blaise Pascal. Blaise Pascal said that it would be necessary to have inequalities between people. It's true, but this is an open door not only to domination but to tyranny. And Coluche said, God said that there will be white men, black men, big men, small men, handsome ones and ugly ones. And all will be equal, and that won't be easy. And then he said that some will be black, small and ugly, and for them it will be even more difficult. So, on a more serious note, the debate on inequalities is a focal debate in the 20th century. And for those of you who don't know John Rawls and the theory of justice, John Rawls is a great political philosopher. He died recently. And John Rawls indicates the conditions in which inequalities could be acceptable, on the assumption that there is what you might call ignorance. That's to say that people don't know what their destiny is when they are born. Let me read this to you, and then we'll take a look at how this applies to health. What he says is that there are 2 principles. Each individual has the right to a system of basic liberties that are the same for everyone and compatible with an identical system of freedom for all. Social and economic inequalities must satisfy 2 conditions. First of all, they must be attached to functions and positions that are open to all, with equal chances in France. And then they must also lead to equal opportunities, and they must lead to the greatest good for the most disadvantaged members of society. It's important to say that in this era that there are inequalities, but some are acceptable. As far as inequalities in the area of health are concerned, because this is a subject that we're dealing with today, there are not only inequalities in the healthcare, but also in the opportunities to get that healthcare. They're measured and classified in 2 categories. You've got external, extrinsic inequalities, the place you live in, your social status, and intrinsic ones, that's to say the fact that the person smokes or drinks, and everybody knows that there's a connection between the 2. You know that George Bernard Shaw said work is... sorry, I'm afraid I didn't get that. Well, anyway, in France, what is very striking for an observer of our health system is the huge gap, which is even bigger than the height of the mountains here. On one side, on the inequalities of rights and the basic inequality in law. But whatever happens, let's say that the pharmacists, there are twice as many pharmacists in the south than in the north of France, because there's a law that says that the ratio of pharmacies per capita is calculated on the national level. But it varies from 1 to 6 according to the area of France. There used to be a map and diagrams that were organized so that everybody had access to the same care everywhere in France. Whatever the expenditure, and although the money devoted to health co is much higher in some areas than others, and in cardiology it can vary from 1 to 9. The radiologists earn 3 times much more money than the GPs, because it's always been the case. And your likelihood of getting good care is going to vary substantially from one practitioner to another and one area to another, because the system is organized that way. So when you talk about health inequalities in France, recent policy shows you an aspect which is a minor one for me, which is the financial aspect. As you know, 22% of the French people say that they get care for too late or not at all. That's essentially in the area of dental care, but it's true in healthcare too. And in the current debate, for the poorest of us who get free care, that's to say CMU, you will just gain about 3 days in the time it takes you to get health care. And everybody knows that when a patient has financial problems, the best thing is for them to get the money back before the money is taken out of their account. And in the area of healthcare, for the last 40 years, I've been looking into the unequal care, access to healthcare. We know the causes of the problem, but we don't know how to act on them. Screening for breast cancer, for example, is a good example, because the same 50% of women have access to the screening, and it's always the underprivileged classes that smoke and don't think that there's any connection between smoking and their health. So I think we need to plead for modesty in this area. Take a look at reality, see things as they are, change public policy when we're not reaching our goals, because there's no connection between the means and the results. So the debate is over. Jean, the social inequalities, because France is not in a good position there. Well, we're not in the worst position, but we're not in a good position either. At the age of 35, between the different social classes, there are differences, and there are differences between men and women as well. Men die earlier than women in any case, don't they? Yes, but that's rather complicated, because in Montpellier, for example, it's a poor region in France. Comes 19th in income per capita, but people live longer in Montpellier than elsewhere. It's all rather complicated, so it's better to be a worker in the south than an executive in the north. Julien, you've worked a lot on inequalities in health. Explain to us, with a totally different health system, things still work. A couple of years ago, you were here at the same table, and you told us that you had a bicycle accident with an electric bike. I think you broke your wrist, and you said that the French system was wonderful because I was managed right away, but I don't know who's going to pay. Do you know who paid for it now? No, actually, I don't know. You can speak English. You have to excuse me. I'm going to have to speak English. My accent is absolutely awful.
I was actually intrigued by the difference that Jean pointed out between what is legally prescribed in France and the reality of inequality. It reminded me of the reactions to my first major piece of research, one that showed that 40%, that the better off professionals, managers, employers, the salariat and their families got 40% more healthcare relative to their need than the worse off unskilled manual workers and their families. These results were widely reported in the press and greeted with a chorus of disbelief. It was actually rather strange. Here we had a system, a heavily centralized system that was free at the point of use. Resources are reasonably egalitarian across the country, and yet the result was that the rich, the better off, were doing much better in the terms of their healthcare than the poor. It appeared to be because of the power of the better off to manipulate the system towards their ends. They were better able to persuade the specialist to give them specialist treatment. But whatever the truth behind it, nobody believed it. Civil servants and academics said in so many words, it cannot be true. It cannot be true that the much vaunted British health service, free at the point of use, designed to provide care independent of income or class, was actually favouring the better off. After all, the National Health Service was an important part of what one English thinker, Tawney, called the strategy of equality, the use of public services to offset the inequalities generated by capitalism. It simply couldn't happen that it was failed, and therefore, exactly as Jean was saying, it did not happen. It was not true. And I think there is an interesting lesson here that the power of belief as to what ought to be true can so often overpower the reality, and most damagingly in the world of policy and politics. One specific point I would just like to make about inequalities in health itself. I've just been talking about inequalities in health care. Inequalities in health itself, our situation, I think, is worse than in France. I think we have the poor. There are differences of about 10 years in life expectancy between the poorest parts of the country, such as Glasgow in Scotland, and the wealthier parts of the country. Very, very big differences in life expectancy between the rich and the poor. A point that Jean makes in his paper is that the trouble is that most public health measures designed to try and raise the average health of the population, such as measures to try and curb the growth of the use of tobacco and so on, these are picked up more by the better off than by the worse off. And as a result, we get a widening of inequality. At the same time as the health of everyone is improving, but the health of the rich improves faster than the health of the poor. There is an interesting little point on that, though. Tobacco taxes are a favourite way of trying to control this. Now, Jean points out in his paper that tobacco taxes are regressive. That is to say, they take a higher proportion of the income of the poor than of the rich. This is true. This is true for us. I imagine it's true in France and elsewhere. There was an interesting piece of research done a few years ago, though, that looked at the impact of an increase in taxation, an increase in tobacco tax, on the smoking habits of the rich and the poor. And what it found was that on the whole, I caricature slightly, but on the whole it found that the poor stopped smoking and the rich carried on. So in other words, although the average tax rate was regressive, the marginal tax rate was progressive. Actually, basically, it impacted more on the poor than on the rich. As a result, the poor reduced their smoking, and as a result, health inequalities, very marginally, were reduced. So I think that's quite there might just be a tool there to use tobacco. I don't know if you would replicate the same result in France. I suspect one might. There might be a tool there for trying to reduce that particular health inequality. So on that note, Chairman, I will stop, and then we'll talk about capitalism in a little while.
Alors maintenant, justement, on va parler du... Now let's talk about healthcare capitalism, or the market economy. Because as you said, capitalism is the exploitation of man by man, and socialism is the opposite. Is that what you were saying? I think that was meant to make you laugh. Yes, I did laugh inside. So could you take healthcare products, 3 examples, healthcare products, hospitals, and the healthcare system organization? Yes, I'll start. I'll be briefer than for inequalities because I think it's simpler. I'll start with a quote from Keynes, who said that capitalism is this belief that the nastiest of men, for the nastiest of motives, will somehow work for the benefit of all. Now, 3 examples: pharmaceutical industry, hospitals, and insurance companies. Let's start with the simplest, which is insurance companies, to say that there is something that to me is extremely obvious. And here I'm referring to 50 years of research that have shown that private insurance in the field of healthcare and also for complementary insurance, it's a bit more complicated, but they actually lead to inflation. They generate inflation. We truly see that the most expensive healthcare systems in the world are systems where people pay the most from their pocket. We see that the German reform and the Dutch reform to open up to a part of the population, let them choose their insurance companies, has led to inflation without any benefit. In the US, they spend 17% of their GDP, whereas the average is 9.5% in other Western countries. The Netherlands, after their reform, increased by 3.5% the percentage of the GDP. The reason is very simple for this. Insurance companies, contrary to what one might think, don't aim to reduce the doctor's income. Actually, the more expensive the doctor is, the happier the insurance company is, and the insurance company is focusing on their margin. So there's a mechanism, an economic mechanism behind this. There are 2 economic mechanisms. The first is linked to the information system, and the second is a research topic that I've been working on, which is the advantage of confidence. When you go to see a doctor, what you're purchasing is not a commodity or service. You're purchasing confidence or trust. You think that the good doctors are the expensive doctors and the good hospitals are the luxury hospitals, luxurious hospitals. So rich people take out insurance to be covered for the expensive doctors and hospitals. And when you have this type of system, this generates inflation. And when you compare the US to other countries, we see that the differences are not differences in volume, they're differences in price. So I think this is quite obvious. So I'm truly in favor of universal health insurance for these reasons. Now, can we come back to universal health care? At the first euro, you said, what about the complementary mutual insurance? Well, that's a little bit more complicated. We can go back to that topic. Complementary insurance, when they are back-to-back with a mandatory scheme, this changes the financing mechanism, but it doesn't change the rationale behind the system. If the complementary mutual insurance covers the excess cost, this also contributes to inflation, indeed. Now, for the hospital, we are lucky in France to have a system that's very competitive, a system where competition is not a competition based on prices, but competition based on services. And here, let me go briefly through this, but we could say, in my opinion, that, and Julian can give us a comment on the English situation, it works well. Hospital management is a very complicated issue. I think it's the most difficult situation to manage because you have a huge amount of processes that take place in parallel. The coordination is very difficult. And this cannot be regulated or with regulations, if you will. Today, Sarkozy's reform with his health minister Madame Bachelot, in my idea, is a Soviet reform, because at the time the president said we need a boss in the hospital, but he chose as a boss, not himself, but there was a direct link between the minister and the hospital directors and the doctors. So my orientation, and Julian can comment on this, would be that we should create in France for public hospitals, public trusts, and make the hospitals independent again. And we stop this regulating authority directly up to the health ministry. 23 years ago, when Claude Evin was the minister, said if we want to change the public hospital system, we should say each hospital is a master of its own structure and has its own rules. It's not up to the state to decide how we organize the units and the wards, etc. And despite what the public hospital staff members say, and despite all of their constraints, the French system nevertheless has shown that private hospitals are more effective than public hospitals. And the difference is at about a level of 30% in efficacy, even if you take into account all of the constraints in the public hospitals. I know my friends working in public hospitals may not agree. This is a great debate. And I've been studying this for 40 years when I worked on the public hospital systems in Paris 40 years ago. And I can show you my calculations. Now, just to go back to the hospital. You said the public hospital should be independent. Today they are autonomous. No, they're not autonomous today. But you say there's an important drift in the hospitals in terms of investments. If they're independent, each hospital is... No, dear friend, let me propose. At the time, I proposed that the hospital would have a president or a chairman of the board of directors with a civil and criminal liability. And there would be a system of course, controlling the accounts and systems of suspension for any ineffective director, of course. But if you want to debate this, it would take an hour, and I can't answer that quickly, but you can see, it seems obvious that the management of the human resources, you see that we have when you talk about appointment of doctors and you try to explain that to anyone, that the cardiologist is appointed by an office in Paris. And I said, yes, that works, but it's very expensive. People think we're crazy when they see our system. So there are 43 families of regulations just on safety. So don't you think we will go from one excess to another, and the hospital, if it's independent, will have only one objective: to develop its own activity? It sounds like I'm hearing the director of the state health insurance here in France. That's what you sound like, and that's not a compliment. We're not half virgin or half independent. You can only be totally independent and controlled, of course. And Julian inspired Tony Blair with his reforms, and he can tell you about these public reforms after I'm finished. Just one word on the pharmaceutical industry. About 10 years ago, I was in Hanoi, and I was lecturing before a group of Vietnamese doctors, and I said that communist countries, and China is an exception to this, but is China communist? We can ask that question. But communist countries will never discover a pharmaceutical molecule. And the interpreter said, should I translate that? But it's true that it seems obvious that we owe the evolution of medicine to the pharmaceutical industry. This industry is highly regulated. Sometimes it could be regulated differently, but it is more interested in the market than in the diseases. For many years, the first research work that I carried out when I was in school, I showed that the pharmaceutical industry was highly linked to the healthcare market and focusing on morbidity rather than mortality. And we know that the pharmaceutical industry has not invested much in tropical diseases, for example. And this is a criticism that we've heard over and over for many years. When you talk about malaria and other types of similar diseases, there has been progress, but I think nevertheless that the capitalist system in terms of the production of goods and services is the least bad. We could debate certain forms of regulation, though. Now, Julian, you worked also in a very state-run system. Could you tell us about competition in the quasi-market? How do you react to what Jean just said, and how did you try to introduce some flexibility into a system that, as you said, wasn't very satisfying in terms of healthcare inequalities? And perhaps you can remind us of what Margaret Thatcher did when she tried to introduce a private system in Great Britain. She sent her advisors to see what was happening in the United States, and the conclusion was, and you can tell us what the conclusion was.
Was that you should never, ever go down the route that the United States has gone down, particularly with respect to the private finance of healthcare, private insurance companies. I remember Jean visiting me when I was working with Tony Blair, and I remember him sitting in a living room in number 10 Downing Street and telling me, for God's sake, do not go down the route of having private insurance companies. And he was absolutely right then, and he is absolutely right now. I think it was I think that was a serious mistake, both of Germany and the Netherlands, to go down that a similar route. But what we are more sympathetic to, and I think both Jean and I are much more sympathetic to, is the role of private providers in providing healthcare, not financing healthcare, but providing healthcare. And actually, there's a general point here concerning the engine of capitalism, which is the role of profit. There's a big debate in England at the moment concerning the so-called privatization of public services. In fact, not just in England, but in other parts of the United Kingdom, the danger of the supposed privatization of the National Health Service played an important part in the important role in the Scottish referendum for independence for Scotland. The role of private providers, especially healthcare, has been very controversial, inviting savage criticism and horror stories about how dreadful they have been behaving across the political spectrum. Now, in a way, this is a bit puzzling. Why is it that privatization or the role of profit arouses such hostility in the case of healthcare? As we've seen, as indeed Jean says in his paper, private hospitals are frequently much more efficient than public hospital. And again, as Jean quotes Deng Xiaoping, if a cat is good at catching mice, then who cares if it is black or white? If private providers can provide us with good quality healthcare, then surely that's all that matters. And I've been trying to, I'm very sympathetic to that view, and indeed I managed to persuade Tony Blair and others in the government to be sympathetic to that view. But I have been thinking a little bit in recent years about precisely why it is that there is this kind of revulsion against profit in healthcare. Now, it can't be because people can't believe that it is wrong to make a living out of providing healthcare. After all, all the people in this room, in one way or another, are making a living out of healthcare. We are, and presumably, in deriving our incomes from healthcare, we are saying that the benefits of deriving those incomes are greater than the costs of providing that income, and that is the definition of profit. So, in a sense, we are all making a profit out of healthcare. So I don't think that people are really objecting to the making of profit from healthcare. I think what they are objecting to is the distribution of that profit, and in particular, the distribution of profit to shareholders. Much of the hostility towards private healthcare, private hospital healthcare, seems to come to an objection to large corporations running healthcare systems, or indeed to large institutions, shareholding institutions providing such care. What seems to be the problem is that people, well, there are two objections to that. One is that the flow of money to shareholders to dividend payments and so on, is money that is lost to the public health system. The public health system is providing the money, it is financing these private hospitals, and there is a flow of those resources that goes into the pockets of the wealthy shareholders. And people object to that. I don't think that's a very strong objection, because actually the amount of money involved is relatively small, 4 or 5% usually, in terms of sort of dividend payments. I think the real objection concerns trust and motivation. For reasons that we all know, the users of healthcare find it difficult, if not impossible, to actually assess the quality of the care being provided. They therefore must trust their provider. If they feel that the provider actual aim is to maximize shareholder value, they might well feel that their trust is misplaced. And they may indeed have a point. I mean, interestingly, this may be a problem not just for healthcare, but in all areas where the users of a service has to have a measure of trust in a provider. Banking and investment systems come to mind. It may be that we may have found here, could it be that one of the foundation stones of capitalism, that of share ownership, is flawed, especially when it's applied in these areas where the user can be easily exploited, as in many public services, and perhaps even wider. If that argument is correct, then what's the solution? Especially if, like Jean and myself, you do not like state centrally, heavily controlled control and management, for all the reasons that Jean has been putting forward. I just want to suggest an answer that may lie an idea that has been actually prevalent in France and in Spain and Italy for some time, although mostly in the private sector, not in the public sector, and that of the service collective. This is where, in the case of healthcare, doctors, nurses, and other staff form a collective or a professional partnership to actually provide the service. In fact, the UK government is quite enthusiastic about this idea and has a programme that is supporting the development of these collectives in a variety of public services, ranging from right across the range from fire brigade and pompiers to leisure services, swimming pools, and so on. But particularly, there have been several developed in community healthcare, and there's one now in acute hospital care. Now, these have been very successful. These have not aroused the hostility, although they are, in a sense, they are private sector operators. They're private professional partnerships, but they have not aroused the hostility that the corporations have. And they have provided an excellent service, very highly rated by the users, and more importantly, even more importantly, they've got happy workers. That there's a high, good well-being to the people working in the service. And none of them so far, we have now more than 100 or so, none of them have failed. They have all none of them have failed financially, which is rather encouraging. So could I leave you with two questions? Yes.
Yes, the collectives. The collectives, so what is their shareholding behind the collective? You said that the problem came from shareholders, profit, etc. So how is it made up from a capitalistic point of view, this idea of the collective?
It varies, but the common pattern is each member of the collective has a share, a £1 share in the enterprise. And some of them then have a sort of democratic system for electing the managers or supporting the managers. It's based on, we have, those of you who visited London will know that we have a very successful department store called John Lewis, which is something like 70,000 employees, and that is a workers' cooperative. It is owned by the people who work within it, and again with a democratic structure for supporting the management. And that is roughly the kind of system which is being proposed here to apply in healthcare or in some parts of healthcare.
D'accord.
Okay, I see.
I just wanted to simply leave you and indeed everyone here with two questions. Ought we to think about limiting the role of shareholding organisations in the provision of healthcare? And if we do, should we think about trying to replace them with some form of professional partnership or public service collective to provide these services?
Alors Jean, les coopératives, vous...
Well, Jean, cooperatives, what do you think? Is this what we're seeing in France? Well, this is something that we have in law now, in fact. Thanks to Parmentier, we have the possibility of creating hospital establishments that are, in fact, cooperatives. You know that cooperatives in France dominate the financial sector, the Crédit Agricole, la Banque Populaire. These are cooperatives in France. You know, the employees are behind the reins. And what Julian is saying is the idea of having cooperatives for public services that would include not only the production of healthcare services, but also some of the GP services. So a kind of formalization, and we'll talk about this again, I expect, over the course of the symposium, but a formalization of healthcare. We can imagine something that might be non-profit making. Why not? You know that the hospital sector is where you have a whole range of possible legal forms. You have SAs, you have congregations, you have Société des Personnes, you have cooperatives. All kinds of legal statuses can be found in the hospital sector. Julien Legrand, for GPs in England, they have a bigger role, I believe, than GPs in France. Now, the current Prime Minister wants to develop their role, wants them to manage directly the purchases for hospitals, the purchases of medications, and that will bring in 20 billion in savings. Now, there seems to be a lot of resistance to this. Whereabouts are they with this idea? Does this follow on from what you did with Tony Blair, or is it quite different?
Yes, it does follow on from what we did with Tony Blair. And indeed, that in itself follows on from what was done under the Thatcher major governments. They had the idea, as you say, GPs, which incidentally are a form of professional partnership in the UK. They are, in fact, actually in the private sector with a contract to the National Health Service. But the idea was that you gave GPs the budget for hospital care for their patients, and that they would then send their patients to hospitals. The hospitals would then charge the GPs, would charge the budget of the GPs for their cost. And the idea was that since GPs were in some sense the gatekeepers to allowing patients to go to a hospital, they would make decisions that were much more efficient, much more economical, if it knew it impacted on their own budget to do so. And indeed, it was rather successful under the Thatcher major governments, this programme. A Labour government came in, the Tony Blair government came in and abolished this system at first, much against my advice. And then later on, when I began to work in government, we began to reintroduce it again, a system by which GPs had greater control over the budgets of hospitals. And indeed, that is part of the present system now under the coalition government. Is it working? Well, it's early days yet. I have to say, I mean, enthusiast as I am for the system, I don't think it will deliver £20 billion of savings. Nothing ever delivers that degree of savings. But I think it will lead to about a higher quality healthcare from the same amount of money rather than a reduction.
Et cette notion de micro-marché,
Is it a kind of a micro market? Is it the quasi-market? Can you tell us about the quasi-market idea?
The idea behind the quasi-market, the micro-market, is that it's very similar to the system you have in France, in fact, in which you have, well, you used to have anyway, you have independent providers of healthcare who compete with one another for patients or for contracts from the government. But the patients do not provide the money from their own pockets to pay for it. The state provides the money. The state provides the money, and the independent providers compete for those contracts. So you have competition. You have some of the advantages of competition, the creations of efficiencies and so on, but without the disadvantages that in wider forms of capitalism that generates the kind of inequalities that we were talking about earlier on when people have to pay out of their own pocket. So you've got healthcare that is free at the point of use, but you have providers that compete with one another to provide the service. And there is evidence, both from the United States and from the UK now, that such competition does deliver benefits. In the UK, hospitals operating in more competitive areas have reduced post-operative mortality. Perhaps, I hope that's a familiar phrase. The mortality after operations have reduced it far faster than have other hospitals not operating in competitive areas.
In other words, does it work? In other words, in France, this is what Julian's saying, we have a quasi-market system in our hospitalization sector. We've got competition between the private hospitals, the ones for profit and ones that are not for profit. So if we don't have any waiting lines in France, it's because we've got these quasi-markets. We are one of the rare countries not to have a queue in our hospitals with a public financing system because we've got private clinics as well. So we can talk about cooperation as well. Is that important? Yes, of course, with the same budget. If you just had public hospitals, it wouldn't work. You would have queues, right? You would be optimizing the work of personnel, but not service to customers. So is it important to have both? No, it's good to have a mix. And this is what the English are doing. Does it work then, Julian? Is this something that's working?
I can speak from personal experience on this because the clinic that mended my wrist in France was a private clinic. And it did an excellent job. And therefore, it must be true that private sector works effectively.
Voilà. C'est important, maintenant on est sûr.
So it's important. Now we know. Now we know. So you have 1 minute to conclude. So rethinking about healthcare capitalism. If there was just one thing to say, one thing to take home, the same for you, Julian, one thing to take away, the main message, efficiency and solidarity we mentioned already. Well, this is for people who take over from me. We've got to evaluate public policies. We are there with a number of regulations for industry, for hospitals, for GPs. There are regulations. And very often, they are useless. They are not effective. They're not suitable. And here we are with some kind of legal fiction surrounding us. We're not really focusing on the reality of the situation. So we need to look at these policies. We need to check whether they're efficient and change them if not. Not just go through a revolution to do this either. Julian, to conclude, a few words.
Say the desirable direction in which we ought to move is for more independence for hospitals, that they can compete with one another, and the development of these kind of service collectives, and maybe on an experimental basis to see how they work. But I think if they do work, we shall end up with greater efficiency and perhaps even more importantly for this colloquium, greater equality.
Merci, messieurs.
Thank you, gentlemen. And we'll now move on to the next debate.